Welcome to the Common Part B Ambulatory Surgical Center Rejections and Denials webinar. My name is Mary Muko. I am a member of the WPS Provider Outreach and Education team, and I'll be your presenter today. I'm joined by my teammates and friends, Ashley Dakota and Bailey Lawson, who will be assisting with some behind-the-scenes help. Now, this webinar today is for those people who are wishing to learn about the most common reasons for rejections and denials on Part B claims submitted to WPS by Specialty 49 providers. That's ambulatory surgical centers. CMS requires the MACs to prevent future claim rejections and denials by providing education on those most common reasons for rejections and denials. And just as advertised, the information that I'm presenting today in this webinar is actually based on WPS Part B claims data. Next slide, please. Here's the objective for today. Of course, we want to help you avoid those rejections and denials. The agenda should look very familiar to you because these are the exact words that appeared in the description for this webinar today. During the next few minutes with you, I'm going to define rejections and denials and talk about the differences. They're very, very different. I'm going to reveal those reasons for rejections and denials based on that claims data that I analyzed. I'm going to discuss ways to fix them or avoid them. And along the way, I'll be providing you with many, many resources, many of which are linked in the handout materials that you should have been able to download. Now, on the next slide, I really begin the whole presentation today with a look at the claims process. In order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process itself. So beginning on the next slide, I'm talking about claim submission, and based on a law that requires that most providers submit claims electronically. There are reports that will confirm claim receipt, and they report even more specific information about the data on the claims. Now, one of those reports is the 276-277 report. The Medicare 276-277 companion guide was prepared by our Electronic Data Interchange, or EDI staff, and it helps submitters understand the claim requirements and know when they need to correct or resubmit the claims. The next slide talks a little bit about the remittance notice. Some people call this the remit. Some people shorten it up, call it simply the notice or the RA. Claims that move past those pre-pass edits that I just talked about that allow that claim into the door, so to say, will generate a remittance advice. Of course, there's many names for this, as I just mentioned, but there are two formats for the RA, the Electronic Remittance Advice, or ERA, and the standard paper remittance. Now, with few exceptions, most providers are going to receive that electronic remittance advice. The RA provides important information to the provider. For any adjudicated claims, you can find information about a lot of things, such as adjustments, denials, missing items, refunds, and sometimes even offset information. The next slide is one that talks about claim adjustment reason and remark codes. And when looking at a remit, you can find various reason and remark codes. These are typically in an alphanumeric format. When claims pay differently than billed, a claim adjustment reason code appears on the remit. Sometimes a remit will also include a remittance advice remark code, and these really just expand on those details that are described by the reason code in order to provide more details about the adjustment to the claim. The next slide includes some information about claim adjustment group codes. This is another type of code on the remittance advice. Group codes assign financial liability for any unpaid balance on the claim. A CO, for example, stands for contractual obligation, and this means the provider is liable and can't bill the patient. If a PR group code appears, it means the patient is financially responsible. Now, On the next slide, I'm talking about that code maintenance. WPS hears a lot of comments about these codes, these reason and remark codes. Providers often, while talking to someone in customer service, say, these codes are really cryptic or they contain outdated acronyms. While we'd really like to help, it is another contractor, not WPS, who maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information should you wish to suggest a change to any of the code lists, including those sometimes cryptic code explanations. On the next slide, I begin to talk about rejections. And as I mentioned a little earlier to you, rejections and denials are really very, very different. And I think a lot of us, those in my office, sometimes providers I'm talking to, and even I catch myself doing this, I use the words interchangeably. And you really shouldn't do this because a rejection is very different from a denial. The actions that you need to consider taking are very different. Let's talk about rejections first. CMS calls these unprocessable. They're not adjudicated. You do receive the remittance notice, but a rejected claim returns on what we call the front end before the claim is actually adjudicated. The reason why Medicare will reject a claim is because something is illogical. It's just missing something, there's incorrect information, or something just doesn't match right. It's illogical. Because rejected claims are never adjudicated, there are no appeal rights. You can't request an appeal. What you need to do is fix it and resubmit it. On the remit for a rejected claim, you'll see an MA130 and a CO16 code. Remember those reason and remark codes and group codes that I talked about. Those are the codes that will appear on a remit for a rejected claim. For a rejected claim, the patient is never liable. You can't bill the patient. You need to fix it and resubmit it. Next, let's talk about denials on the next slide. Denials are claims that are actually adjudicated. We deny claims because the claim failed to meet payment criteria based on that information you've placed on that claim. Now, this slide includes some examples of reasons why we may deny a claim. There may be a law that says we cannot pay for an item or service. Those are known as statutory requirements. Sometimes the item or service that you're billing for doesn't meet Medicare's medical necessity requirements. We might deny that claim. Medical necessity denials also include any frequency denials or any denials due to utilization parameters or guidelines. Whenever you have a claim that denies due to medical necessity, or you believe the likelihood that Medicare may deny a claim due to medical necessity, that should be one of those situations where you consider presenting your patient with that advanced beneficiary notice of non-coverage, or the ABN. Remember, you need to do that before you render the service in order for that patient to make an informed decision about whether he or she wants that service. Another type of denial, and one that's quite frequent that I've listed on this slide as an example of a denial, is an eligibility denial. Now, this denial could be eligibility of a beneficiary or your patient versus eligibility for a provider. So different types of eligibility denials. When you're looking at a remit, typically, or most often, with few exceptions, you're going to see an MA01 code on it, and the MA01 provides appeal rights. Of course, for denied services, patient liability is determined on a claim-by-claim basis. On the next slide is the transition now of whether you need to correct or appeal a decision made by Medicare on your claim. So let's take a look at some of those potential actions to choose here. After reviewing your RA, you're going to need to choose the action that you take. For an unprocessable or a rejected claim, you're going to need to fix the error and resubmit that claim to Medicare. Now, if the claim or a claim line denied, there may be multiple actions to choose from. For a denied service, you might be able to simply resubmit the service. You might be able to use the clerical error reopening process to fix a clerical error. And CMS defines these as human or mechanical errors on the part of the provider or the contractor. Another action to consider on a denied claim is an appeal. The remittance advice is going to provide those appeal rights. I'll discuss appeals in just a minute. Registered users can use our SecureNet Access portal, what we call SNAP, to render or request a clerical error reopening or to render an appeal. Now, this is just one of many self-service tools that WPS and other MACs offer that really do offer the most efficiencies when you're considering actions to choose to make a correction or request an appeal. Our portal user manual provides illustrations and step-by-step instructions on how to use this portal feature, this and other portal features. And Ashley, I'm going to ask you to open up and show the WPS homepage of our website, because I want to show you where you can find that portal user manual. We show it in, or we allow it, or we actually make it available, rather, a link, and Ashley's showing it there on all of our web pages, but you can find it in this large blue box that you use to log into or register for SecureNet Access portal. The portal user manual, as I mentioned, provides you with illustrations and step-by-step instructions on how to use all of the functionalities of SNAP, our SecureNet Access portal. If you scroll to the bottom of any one of our web pages, and I'll ask Ashley to do that, there's a large blue box at the bottom of each web page, and under the heading Educational Opportunities, you'll also find a link to the portal user manual. Very, very helpful when deciding to use SNAP to perform any of these self-service efficiencies. Let's take it back to the PowerPoint. On the next slide, I've included a little bit of information about appeals. This is just important for you to recognize that when a service is denied, this is one of your options. Typically, most often, an appeal is allowed for a denied service. There's just few exceptions when there are not. I'm not going into this in a lot of detail, but I do want to talk about it just a little bit because it is one of those actions you can choose to receive payment or to request payment for a service that the MAC has denied. For claim denials, most often you can request this appeal, and of course the purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by MACs. The beneficiary or his representative or her representative may request an appeal on any service that's processed for them. But for providers and suppliers, they can appeal services for which they accepted assignment. And for unassigned claims, providers and suppliers can act as that beneficiary's representative, but the beneficiary would need to sign an authorization statement. Additionally, providers and suppliers can request a redetermination on a non-assigned claim for two reasons. If the service is denied as not medically necessary, or if that provider or supplier billed in excess of the limiting charge. And of course, in those situations where the provider has collected from the beneficiary, they would need to refund any fees collected in excess of that limiting charge. Now, there are 5 levels of appeal. There's only one level that WPS does, or any other MAC does, and that is the first level of appeal called a redetermination. It's the only level rendered by the MAC. There are time frames to request or to file a request for an appeal that apply to all 5 levels. There are also time limits for completion that apply. And what I'm talking about here is the time it takes the contractor to render their decision and send you notice. Now, those time limits for completion, though, apply only to the first 4 levels of appeal. They do not appeal to level 5. There are 2 levels of appeal that have amounts in controversy, and these are really just dollar thresholds that you must meet in order to request that level of appeal. Level 3 is the administrative law judge or ALJ hearing, and level 5 is federal court review, and both of these have an amount in controversy. And you can combine similarly denied services in order to reach that minimum amount in controversy, even if it's for different patients. Medicare will allow that. On the next slide, I've included some resources for you. I could do a whole presentation, 60-minute presentation on appeals alone, but today we're talking about that data that I want to get to and share with you. So we're just touching on appeals. The first bulleted item here is how to appeal a claim determination, and that is a website resource. The second resource is one of my personal favorites that I like to share with any audience when I'm speaking about appeals. It is a flow chart that CMS updates annually. And if you could, Ashley, click on the link and open that flow chart so I can talk about it a little bit. Should open right up. There are 2 separate processes on this flow chart that I'm showing, or that Ashley's demonstrating here. The standard process for parts A and B is on the left. The expedited process is on the right, and that applies for some part A only. Today, as advertised, this webinar pertains only to Part B. So we're talking about that left side of this flow chart. You'll see the initial determination there. That's the max initial determination, meaning the claim decision when we processed your claim. We adjudicated your claim. You have 120 days to file the first level of appeal, which is done and performed by the MAC. It's called a redetermination. You'll see that in that box right under the arrow that Ashley's moving around. And there is a 60-day time limit that the MAC has to render and send you notice of their decision. You then have 180 days to file a second level of appeal if the decision by the MAC was not fully favorable or partially favorable. That shows the second level of appeal is the reconsideration rendered by the qualified independent contractor. They have 60 days to render their decision and send you notice, and so on and so forth. You can see the third level of appeal there, the fourth level and the fifth level. I really like this chart because I can quickly look at it and I know how many days you have to request that level of appeal. I know how many days the contractor has to make their decision. I know the name of it. And also for the third and fifth levels, remember that amount in controversy that I talked about? This flow chart includes that. So you can see for level 3, the amount in controversy is greater than or equal to $190. And the amount in controversy for federal district court is $1,900. Now, one thing you might notice here is that there's no time limit for federal district court to render their decision and send you notice. That is the only level of appeal where there is not a time frame attached to the amount of time the federal district court in this case has to render their decision and take notice. And the reason for this is that it takes some time often for cases to get onto the federal district court's calendar. So there's no stipulated time frame for them. If we go back to the PowerPoint, the next portion of this presentation today is really the data, and that's what it's all about. This is what I advertised that we would talk about today. I want to share actual claims data with you so that you can avoid these rejections and denials in the future. The data dashboard is an interactive tool. It was designed by our data analysts in what we call our Insight department. That's the name of that unit at WPS that's responsible for mining the data and looking at data trends, among other tasks and responsibilities. I'm going to have Ashley show you what the data dashboard looks like. The data dashboard is the tool that we use, people like Ashley and Bailey and me and my other colleagues in provider outreach and education, to look at and analyze rejections and denials. We can look at trends. We can look at rejections or denials by state. We can drill down to county. We can throw a CPT code in there and look only at a specific code. And simply by a click of the mouse, we can change this data that we're asking for. Ashley, I'm going to ask you to place 64494, a CPT code, there into the drop-down menu. Our data team calls these data slicers, and you can see how quickly the information changed. So right now, if you look from left to right in the green boxes at the top, you can see the various filters or those data slicers, all jurisdictions. We're looking at Part B. We're looking at denied claims by specialty 49. Well, what does specialty mean? Some of you may be wondering that. Specialty is a two-digit code assigned when you successfully enroll in Medicare Part B. Each different provider most providers can self-designate, some don't. They can designate their primary specialty, and it is that primary specialty that is used during initial claims processing. So it is there looking for information, those edits and audits that pertain to that provider type. So in your case, you are specialty 49. If you're an ambulatory surgical center joining me today, that's the data that we're looking at and I'm providing information about during this presentation today. So really quickly, let's take a look at unprocessable claims there and change that one, Ashley. You might need to take the CPT code out also. Nope, actually we have some rejections for that code as well. Both rejections and denials, it tells us the reason. So this is what you could go back to the PowerPoint now, Ashley, while I'm talking here a little bit more. This is what we use to monitor those rejections and denials and determine a need for what we need to educate on. And it is in CMS's internet-only manual that they state that this is a requirement for provider outreach and education. And again, this is exactly the reason why I'm providing this information today. So I looked at all of our jurisdictions, both Jurisdiction 5 and Jurisdiction 8. That means Part B claims data for Indiana, Michigan, Iowa, Kansas, Missouri, and Nebraska. I looked at rejections and I looked at denials. I looked at the reasons why we are rejecting claims for ambulatory surgical center. And I also looked at the codes that we are most commonly rejecting and denying for your specialty. And I also looked at trending. Let's take a look at those data results beginning on the next slide. Those are the data slicers I talked about. So one more slide. All right. Here then, I am revealing the most common rejection reasons for your specialty for the time frame that I looked at. And Ashley, I apologize. I'm going to have you go back 2 slides, I believe, and show you there, that slide. I apologize. Only one. Sorry about that, folks. This is what happens when I don't have control. Thanks, Ashley. You're doing a great job getting me to where I need to be. I looked at claim submission dates July 1 of 2025 through September 30 of 2025, and the data was just refreshed on October 13th, so not too long ago. We refreshed that data. That means our data team refreshed it to bring us the latest and greatest information for these data slicers and the data that I'm analyzing. Now we'll move on and look at those most common reasons. The number one reason we rejected specialty 49 claims for those claims submitted during that time period is because the claim included or didn't include, it had incomplete or invalid plan information for other insurance. What that means, folks, is that you told us there's another insurance, but you failed to put the information on the claim that we need about that other insurance. Ashley, if you would please pull over the crosswalk. I want to show you. CMS in their internet-only manuals has instructions for what you need to put where on the claim, what the data element is, what is the requirement, what is the description of that. Most providers will submit electronic claims, and a lot of times that education that both we provide and CMS provides will give you the instructions for the paper claim. So if the paper claim, item number 1, includes the type of health insurance, which is showing here on this crosswalk, Where do you put that on an electronic claim? And what is it you need to fill in on that electronic claim? This crosswalk provides for you the item number of the paper claim and then the narrative, what it is you're adding to that claim, and where you need to put it on that electronic claim. Okay. If you scroll down a little bit, let's go to item number 11. Just another example. I'm just picking something out of the air. If it goes in item 11 on the paper claim form, where does it go on the electronic claim form? Another thing I want to point out is the status code column on this crosswalk. You'll notice some S's there, and down at the bottom in the last box there, the last row for status, there's an R. R, as you can see at the bottom of each page of this crosswalk, is any data element that is needed in order to process a claim. And S means that the data element is situational. You need to complete it, but only if other conditions exist. This is important when, as you're talking about, or as I'm talking about, rejected claims. If there's a required element or an R in that status code column and you fail to put that information on the claim, your claim is going to reject, or that claim line will reject. It's a required element. Sometimes it's missing a situational element. And in this case, you've told us that there's another insurance plan, but you didn't give us the information we needed about that plan. So that's a situational component of that claim, and we rejected it. What do you need to do? You need to fix it and resubmit it. Back to the PowerPoint. All right, let's take a look at the next most common reason for rejections. It is missing, incomplete, or invalid procedure code. Maybe you put the code there and it simply was transposed when it was typed. Maybe it's an invalid procedure code because it's no longer valid. It's an old code. Maybe it's incomplete or missing altogether. That's a reason for rejection. The next is invalid or missing modifier. And we have fact sheets out on our website. Ashley, if you could please go to the WPS website. Let's take a look at one of those fact sheets so you get a good idea of what's on those fact sheets and how really helpful they are. Let's go. I'm a searcher, not a navigator, so I typically just put modifiers up in the search box, but you can also navigate to the modifier fact sheets by going to our Claims Topic Center. But let's take a look at modifiers, either way, whichever way you want to go. Thank you. And again, just as a reminder, any of these great resources that I'm talking about or showing you here, I've embedded links in your handout so you can come back to them later. Let's go to the modifiers webpage. Scroll down if you would, please. And notice all of these, including ambulatory surgical center modifier fact sheets we have available out on our website. Choose one if you would under the ambulatory surgical centers. And let's look at an example of a modifier fact sheet. The modifier 74. For all of our modifier fact sheets, we include the definition, and you'll also see appropriate use and inappropriate use. And very often, we'll also add some additional information. Okay? In this case, we've added additional information and multiple procedures when surgery terminates. Sometimes we even include CPT codes to which you can append that modifier. So helpful information if you get this type of rejection. You need to fix it, resubmit it. Back to the PowerPoint. Third most common or fourth most common reason for rejections, your specialty, is that the claim must be submitted to the Railroad Retirement Board, which is Palmetto GBA. If the beneficiary is a railroad retiree, he or she's Medicare, his or her Medicare claims must be submitted to the Railroad Board specialty contractor, which is Palmetto, not WPS. So fix it, resubmit it, but don't submit it to WPS. We're your MAC for Iowa, Kansas, Missouri, Nebraska, Michigan, and Indiana. But if that beneficiary is a railroad retiree, it goes to that specialty contractor. How do you know it's a railroad retirement beneficiary? If you're looking at their Medicare card, it's going to look very similar. The emblem on it is actually a little different, and at the very bottom of the front side of the card, it will say Railroad Retirement Board. Missing procedure modifier is the fifth most common reason for rejection. And then the next one, it says this claim has been forwarded to Palmetto, the railroad retirement beneficiary specialty contractor. Really means the same as the fourth most common reason, but in this case, you don't need to fix it and resubmit it because the claim has already been forwarded for you. And that is dependent on the agreements that some supplemental insurers have with Medicare, that we forward the claim on your behalf for certain rejections or certain denials. Okay. There's an agreement between WPS and that other insurer. In fact, the other insurer actually pays a fee for each claim that they ask us to forward on their behalf. Next slide, please. Let's look at more rejections. Missing, incomplete, invalid name, strength, or dosage of drug. Missing, incomplete, invalid ordering provider number or billing provider identifier, primary identifier. These are all in order yet of the most common reasons we reject claims. Obviously, if you're giving or billing for a drug, you need to include that name, strength, or dosage of the drug in the claim. Typically, that's going to go in item 19 or the electronic equivalent. For Medicare services, certain items or services require an ordering provider. You need to enter that on the claim. Obviously, you need to enter the billing provider's primary identifier as well. Back to ordering, though, just for a moment. CMS publishes every year, or publishes and makes available on their website, a referring and ordering list of providers eligible to refer and order for the Medicare program. And it also includes their national provider identifiers. That's one of your many resources I've included links to at the end of this presentation. Another reason we reject your claims is that the description of the service is missing. It kind of goes along with the name, strength, or dosage of the drug. If you're missing information, your claim is going to reject. You need to fix it, resubmit it. Rendering physician number is invalid or missing. Sometimes it's simply typed wrong. Maybe it's missing altogether from the claim. So you fix it, resubmit it. Let's take a look at those codes that are the top rejected codes for your specialty. In order, again, 66984, which is the extracapsular cataract removal with intraocular lens implant. That's the #1 rejected code for your specialty. There are the reasons. We've already talked about those. 99070 is unlisted supplies and materials. You can see the reason why we have rejected it, as well as the A4550, which is a surgical tray. It's missing, incomplete, or invalid procedure code. You can't bill those services. Fix it, resubmit it. On to the next slide where we have some more codes. 45385 is your flexible colonoscopy with removal of tumor, polyp, or other lesion by snare technique. The reason we're rejecting this is there's an invalid or missing modifier, or the claim must be submitted to the Railroad Retirement Board contractor. G0121 is a colorectal cancer screening via colonoscopy, and you'll see the reasons there. We've talked about these already, all of them, why we're rejecting that service. Just kind of a heads up for you of what you need to fix before you resubmit. On to the next slide where we talk about trending. I mentioned this earlier, that we're monitoring trends. We're looking at trends. We can use that same tool that Ashley showed you to show us trending. So I looked at trending for Specialty 49 ambulatory surgical center claims during that same 3-month period of claim submissions, and found for the current 3 months of the data that I looked at, there were 227 rejections because the claim must be submitted to Railroad Board. The prior 3 months was only 107 rejections for that same reason. The difference is 232 claims. That's a 159% increase. So that tells us that we may want to provide some education to the provider community, to our customers, about these claims that must be submitted to the Railroad Board contractor. And that, folks, is exactly why I am offering up this series of webinars about rejections and denials for each of the specialties out on the specialty code lists. is that I want to provide this education to you so we can reduce those rejections and denials. Next up, I'm switching gears now. We're talking about not rejections, but denials. These are the claims where you're going to need to or consider requesting an appeal. The number one reason we denied claims, and I did not look at those quality reporting codes that ambulatory surgical centers must put on that claim. I disqualified or I took away any data for those codes because obviously those codes aren't service codes that are payable, so we don't want to include that in the data. The number one reason we deny your services is the service cannot be billed separately. It's a service that cannot be unbundled from a primary service that's being rendered on the same day. Some of these kind of codes are add-on codes where you need to bill another code first before we can separately pay. Sometimes these are situations where out on the CMS relative value file, there's a B in the status code column. If there's a B in the status code column of the relative value file, which is included in your resources, if there's a B there, it means it's bundled. Medicare will never unbundle payment for that service. And then again, we have the National Correct Coding Initiative edits that will look at procedure to procedure edits to see, is there a modifier you can append to that column 2 code so that you can unbundle payment and receive payment for both. Similarly, third most denied reason, payment included in another service received on the same day. That's a bundling denial. Incomplete and valid plan information for other insurance, and statutorily excluded services. Now, this kind of makes sense to me because I know for ambulatory surgical center, there are certain services or items that you provide that are not covered based on a law. That's what we mean by statutorily excluded. You don't really have to submit those services at all to Medicare unless your patient asks you to do so. So, I mean, I would expect to see this there, but I know that there are certain services excluded. So obviously we're going to see denials for this, but unless your patient asks you to do so, you don't need to submit that. We do recognize that many of you are submitting those excluded services because the patient's supplemental insurer wants that Medicare denial. Next slide for more denial reasons. Collection of fee-for-service during periods of managed care. That means that the beneficiary has elected Medicare Part C coverage. They have elected enrollment in a Medicare Advantage plan. So WPS, your MAC, can't process that claim and make payment. Next, look at the next one and the next one. Duplicate charge paid on such and such a day on claim such and such, or this is a duplicate charge. We process every single day thousands of claims that are duplicates. There are certain situations where we understand and acknowledge that a repeat procedure is being done for the same patient on the same day by the same provider. If that's the case, you need to consider appending a modifier to that service so that it tells us, or the computer logic will recognize that it is indeed a separate service done twice the same day or 3 times or 4 times. So look at those modifier fact sheets to see if you're getting this kind of denial and it really isn't a duplicate service, if you can fix that or how to fix that, what modifier you can append. Another thing you can do to avoid this denial is to stop sending your claims on a cycle basis. So, for example, if you or your billing service, if you use one, automatically submits claims on a 30-day basis, every 30 days that claim comes in, comes back to Medicare, you need to stop doing that. It is considered abusive. You should not just automatically submit a claim to Medicare if you have not checked the status of that claim. So those are just some things to do to avoid those in the future, or to fix them if you need to. DME should be sent to the carrier that services zip code area. This is a situation where on that claim to WPS, you included an item or service that needs to be submitted to the DME, the Durable Medical Equipment MAC, not to WPS. And the last one is not covered in this place of service. Next slide, please. I want to show you the codes that are rejecting. Many of these reasons we've already talked about, but these are the top denied codes in order. For specialty 49, the first is the posterior chamber intraocular lens. This service cannot be billed separately, or Medicare doesn't pay separately for this service. 64,494 is second level paravertebral facet joint injection in the lumbar or sacral spine, followed by the 64636, which is the destroying paravertebral. That's a tough word for me, folks. Sorry. Paravertebral facet joint injection in the lumbar sacral spine can't be billed separately. We don't pay separately for that service. The L8699 is the prosthetic implant, not otherwise specified. So it's an NOC code. You need to give us more information. We are denying this service for the reasons there on that list. We've talked about all of these already. So let's move on to the next slide and look at more codes. 66984 is the extracapsular cataract removal with the IOL implant. Duplicates. We're denying this for duplicate. Chances are what's happening here is that the service is coming in. It may be denying, you're resubmitting a claim or submitting a new claim before you're establishing the status, or maybe you're just submitting a new claim because you think that it's going to pay them the next time. That's not the case. It's going to deny as a duplicate. So avoid those. 64,491 is the injection. It's diagnostic or therapeutic agent into that facet joint. Service cannot be paid separately. Medicare doesn't make separate payment for the service. And then the V2787 is an astigmatism correcting function of an intraocular lens, and that is a statutorily excluded service. You know, maybe you're billing it because the patient said, I want you to submit it, or maybe another insurance might consider it if Medicare denies. I do want to show you really quickly our YouTube channel, if you would, Ashley. I talked a lot, there were a lot of these codes that I talked about today when I talked about denials that dealt with those facet joint injections. Look for policies about facet joint injections, and also out on our website, not just for facet joint injections, but for all kinds of topics. We have many playlists. We have videos that you can come out to and watch previously recorded webinars if you're interested in learning more about those facet joint injections. Also on the CMS website, their Medicare coverage database will enable you to enter the MC. Let's look for the Medicare coverage database. When I look for that, I just put MCD in the search and it pops up. The MCD search, the second one there, Ashley, MCD search. Second one down in the middle of the page. Yeah, you just needed to scroll a little bit. Scroll a little bit and choose. There you go. Thanks. What Ashley's doing is opening the Medicare coverage database. That's a national searchable depository for all national and local coverage determinations, and it doesn't want to open up right now. Simple to use. They've also published an MLN how-to article of how to use this search mechanism, and it doesn't want to open for us now. Let's just go back to the PowerPoint. But if you look at that MCD, and CMS updates their website on Thursdays, so maybe there's just so much going on right now, it's not wanting to open for us. But if you take your CPT code and put it into the search box in the Medicare coverage database, you'll be able to see results that would include any local coverage determinations by the MACs. Just make sure that the one you're looking at and following is WPS's. Okay, so some good information there. Back to the next slide. Let's talk about some trending for denials, specialty 49. This one is that the claim must be sent to the EGHP first. Well, that's how it prints out on the website, so that's how I placed it here on the slide. But EGHP stands for employer group health plan. That is the situation where Medicare would be the secondary payer, because based on information in Medicare's files, there is another insurance and employer group health plan that is primary and should pay first. So send the claim there first. Current 3 months, $399, prior 3 months, $167. The difference is $232. That's a 139% increase. So people like Ashley and Bailey and me would say, do we need to do education on Medicare secondary payer program? We have done education on it, a lot of it. You know, and the difficulty with this is eligibility for a patient changes. They might have employer group health plan this month, but not next month, and so on and so forth. Or Medicare might be primary, and then Medicare's no longer primary, or another insurance is primary. We know that changes, you know, here and there based on eligibility files in the common working file. But we have education about the Medicare secondary payer program, many videos available out on that playlist on our YouTube channel. Let's take a look at some more information that I placed here into the PowerPoint for you on the next slide. I'm just including some slides here that you can come back to later to facilitate some of those fixes that I talked about for rejected claims. Here's how you could fix modifier issues. You know, make sure that you're adding a modifier when you need to. Make sure that modifier is valid for the procedure code you used it for or you appended it to, and make sure it's valid on the date of service you billed. Next, please, is patient eligibility fixes. You know, maybe that patient name on your claim doesn't match exactly the patient name on the Medicare beneficiary's card. If there's a middle initial on their Medicare card, it needs to be on that claim. Make sure you're submitting services to the correct payer. If they have Medicare Part C, send it to the Advantage plan. If they're a railroad board retiree or a railroad retiree, send it to the Railroad Retirement Board contractor. The next is provider number fixes, just some information there. If you're receiving rejections due to the invalid or incorrect provider number. Next, I've included information on the next slide about duplicate denials. I talked about this already. No, don't auto resubmit prior to establishing status. So if you're billing on that cycle basis, stop doing that. Make sure you're billing appropriately and using those modifiers that tell us or tell the computer, the MCS, the computer logic will recognize that it is indeed not a duplicate service. Next is MSP denials. I talked about the YouTube channel playlist that we have. Here's a link to it. CMS has a web page that MSP questionnaire is available to help you discern if your patient has another insurance that's primary to Medicare. There's also a fact sheet that I've linked to. And on the next slide, there is information, or I'm actually providing for you a separate section at the end of the presentation with even more resources and tools. I talked about claim form instructions. These are those internet-only manual claim form instructions I talked about. The Part A claim, the Part B claim, and then I've included a link to the EDI and EDI support requirements also. On the next slide, we have some information about the IVR, which is where you can find claim status and details. This is a self-service tool. You use your voice or telephone keypad to get information 24 hours a day, 7 days a week. There is limited functionality outside of normal business hours. And just like the portal user manual, we have the IVR operating guide to help you use that self-service tool. The next slide is about the SecureNet Access portal, and Ashley's already showed you where you can find the links on our website to that portal user manual, much like the IVR 24 hours a day, 7 days a week. The SNAP has actually not only claim status, but claim details and claim actions, and you can check eligibility using this self-service tool. So there's the big difference between the IVR and SNAP. With SNAP, you can check eligibility. You can no longer see eligibility information on the IVR by using the IVR. Next, please. Here is a website resource for rejections. Now, we talked about, or I talked about reason or remark codes. Look at your remit when you receive it. If there's a reason or remark code on there and your claim was rejected, come out here to this resource and look for that reason or remark code in the resource, and it will tell you what you need to do to fix it. On the next slide, similarly, I've included a link to a resource on our website, but this time it's for denials, not rejections. These we have categorized in the resource. We talk about bundling denials, there's global surgery rules, entitlement denials, provider number denials, duplicate denials. Once again, if you're looking at that remit, go to that reason or remark code, come out here, and it will give you some advice on how to fix not fix, but to what you need to do to correct that denial. Next is just a ton of resources available. The website, of course, how to request a clerical error reopening is for those clerical errors that I talked about. If your claim rejects, you may or you may not be able to use a clerical error reopening, and you can do it yourself, which is more efficient. Get it done more quickly if you actually do it yourself using SNAP, our Secure Net Access Portal. But for those minor clerical errors and omissions, now there are certain things you can't do. You can't do the reopening on using SNAP, or we can't do it. You have to resubmit your claim and get that fixed. Modifiers webpage, we already looked at those fact sheets. Timely filing of claims really didn't pop up on the radar for Specialty 49 claims, but it has been problematic for WPS in that people aren't submitting their claims timely, and mainly when that's happening is when another insurance pays first, and then years later, sometimes they'll come back and they say, well, we really weren't primary, Medicare was, you need to submit to Medicare, but your time's up. You can no longer submit a timely claim. Those, so says CMS, are not eligible for a waiver of timely filing. That is not a reason for the MAC to reopen your claim and process it. Those situations where the error was made due to a third-party payment being made. That article, or that resource rather, Timely Filing Claims, talks about that. It also talks about those situations where you do have a bona fide reason for filing late, and you need to request a waiver of timely filing. The durable medical equipment claims lists are available on our website. One of your denials, I believe, was for the L8699. Sometimes I know that ASC claims or ambulatory surgery center claims include items that are prosthetics, orthotics, and such. Those aren't processed by WPS, and these jurisdiction lists will help you ascertain whether it's a DME MAC or WPS MAC claim that you need to submit. On the next slide, there are more resources. Billing for NOC codes. One of your denials was the 8699, L8699. So this just helps fill you in on what you need to include on your claim and where when you're billing an NOC code. Live events, Encore Presentations are recordings of our webinars that are available for 60 to 90 days on our website. And they're also included on our YouTube channel. And I've just included here that we do have a timely filing exceptions recording out on our YouTube channel. Next slide is the EDI webpage. This is where Ashley went before we started the webinar today. She went out here and grabbed that crosswalk. I also made a comment or talked about the companion guides, that 276, 277 companion guide. When you're looking at those pre-pass edit claims, when your claim, we do or we don't allow a claim to come in the door, so to say, your electronic claim. So those 276, 277 companion guides are also available out here on the Medicare EDI webpage. And their website is actually separate, the Medicare EDI webpage, than our WPS Medicare webpage. Next up is even more resources. I have CMS resources, checking eligibility. That is a big reason for denial, not just your specialty, but a lot. We make a lot of denials based on eligibility or failure to meet eligibility. So that should help you, that fact sheet. The review contractor directory is an interactive map out on CMS's website. You can click on your state and it tells you where to send which claims. Who is your RAC, your recovery audit contractor? Who is the unified program integrity contractor for your state? So it's a state by state interactive map that will tell you where your claims need to go. Is your patient a railroad retiree? Are they a coal mining retiree? Where do you send those claims? Ordering and referring files. Is that list of ordering and referring providers eligible in the Medicare program to order and refer? It includes their national provider identifiers. We also have a place of service code set, which explains the proper 2-digit codes to use when entering place of service on your claims. And on the next is that Medicare coverage database that we weren't able to pull up today. It wasn't allowing us to open. It may have eventually, but it might have taken time that we don't have. You could see we're just before the hour here, so I need to wrap things up. But there is that how to use the Medicare coverage database Medicare Learning Network publication that's available that will help you use that. We also have offered in the past webinars on use of the MCD, so you can look out in our YouTube channel for that. We talked about bundled services. If there's a B in the status code column of the physician fee schedule relative value filed, it means that there is absolutely nothing you can do ever to get that service paid for by Medicare. This is a hard-coded denial in the system. If that B is in that status code column, it's bundled. There's no modifier you can append to any code to that code to receive payment. Always denied, never payable. Next up, more of those bundling type edits, specifically the procedure to procedure edits, are going to tell you when you can or cannot append a modifier to the column 2 code in order to unbundle payment for the column 2 service. That's the service rendered on the same day, but for the same patient by the same provider during the same encounter. There's also those add-on code edits that might be useful to you too, because we had talked a little bit earlier about those facet joint injections that were being billed. If you don't bill the primary procedure first, then that add-on code is going to not be payable. Next is time for questions and answers, and unfortunately I'm showing we are just 2 minutes before the top of the hour. I don't know, because I can't see if there are chat questions that are being entered as we move along. Typically for these I have had few questions come into the chat, but if you have a question that you entered into the chat that pertains to what I talked about today, not a claim specific information, those need to be covered or answered in customer service, I'll be able to send you via email an answer to your question. So keep that in mind. You'll be able to do that. And also for a period of 7 days following this event, if you look in the notes section of the slide deck, on the last slide, you'll see how you can send a question for 7 days following this event, a presentation related question that is, to wps.gha.education@wpsic.com. And I will prepare an answer and send it either directly to the person that sent the email in the question, the follow-up question, or I will prepare a list of all of the questions and answers and send them out to all of you. Okay. Finally, before adjourning for today, I do want to let you or remind you about the importance of the survey that we're going to ask you to complete following today's webinar. I want to know what did you think of this experience today? What would you like to see us offer for future education? There is a survey link that Bailey is placing into the chat. There's also going to be a redirect. When you exit the webinar today, there's going to be a pop-up box saying, hey, you're going to another website to take a survey. It's going to look at what you see here on this slide, or it's going to look like that with the yellow triangle at the top. It's not malicious or anything. It's okay if you've not already completed that survey to do so. This survey is just so very, very helpful in letting us know which direction we need to go with our education. We also had some great ideas that you folks have submitted to us that we've been able to implement. You know, we added training indicators to our webinar descriptions, so you'll know if that education is designed and will be helpful to you and what you do at your place of business. You know, is it a compliance issue? Is it a clinical issue? Does it apply to those in coding and billing, so on and so forth. We've also added chapters to our YouTube videos, and they are just breaks within the video that you can see in a bar at the bottom of the video to move from one topic to the next if you don't want to listen to the entire presentation. It's kind of like the table of contents in a book. You can get to where you need to get to very quickly with skipping over some and coming back to others. Now, some of you may be seeking some continuing education units for this education today. If so, look in those notes that are provided on the last slide in your presentation materials. And we're going to get to that right now because Ashley's going to show you that final slide. If you are looking at that PowerPoint that we have shared with you, you will see that you will receive a thank you for attending email from WebEx. That's our webinar platform. They will send you that email, and in the body of the email is that language that serves as your certificate of achievement that you can present to an accrediting body to receive or for them to consider awarding you with continuing education units. Now, if you get an email that says, sorry, we missed you, that's because you joined by phone only, and there's no record of your email address, or you will receive the email rather, but we can't confirm your participation if you dialed in. So in that case, you'll need to send us an email to the WPS mailbox. You'll see it there right now in your chat because Bailey entered it there. You'll need to let us know the name of this presentation and the telephone number you called in, and we should be able to verify your attendance, your participation today, and send you that email that will have in the body of the email the verbiage that serves as your certificate of achievement. At this time, I do want to thank you for joining us today. We appreciate your taking time out of your busy schedule to do that. If you submitted that question in a chat or each question in the chat, remember I'm going to promise that I'll send you an answer, and you have 1 week from today to submit other follow-up questions that pertain to what I talked about today. Claim-specific questions do need to go to customer service. So at this time, on behalf of Ashley and Bailey and myself and our provider outreach and education team, I do want to thank you for joining us today. Remember to take the survey. Your feedback is really invaluable. Thanks and have a great day.